So myself, Dr. Abhijit Patil, greetings from Nadiad. So the topic is orthotopic and auto kidney transplant. Now, what is auto transplant? Okay, so auto transplant is so you remove a kidney of a person, you perform something on that kidney, and again implant the kidney on the same patient. So the basic difference between auto transplant and orthotopic transplant is that there is no immunosuppressants required in auto transplant, but orthotopic will require an immunosuppressants. Now, what are the scenarios where you'll actually have to remove a kidney and implant in the same patient? Why will you do so? So there are certain indications for doing those. So let us understand. So kidney has three structures: artery, vein, ureter. Okay. So anything related to artery, vein, ureter complex structures or complex pathologies, you would like to remove the kidney, treat it on the bench, and again implant the kidney into the patient. So suppose you have a case of renal artery stenosis which is very bad or which is very long. Okay. So in that case, you would like to remove the kidney and manage it. Aneurysms, small aneurysms can be managed conservatively, or if they are large enough, you want to resect it, then it is better it is excised. You remove or reconstruct the aneurysm in vitro and then implant the kidney back. Everybody knows about nutcracker syndrome. So nutcracker syndrome, there is obstruction to the renal vein outflow, that is why the kidney gets congested. And the most common treatment of choice for nutcracker syndrome is transposition of the vein over the inferior mesenteric artery. But suppose it does not happen, then what you have to do is you have to explant the kidney and obviously put in the iliac fossa, then your obstruction of the renal vein is taken care of. Complex ureteral issues, suppose there is a ureteral avulsion, then what would you do is you would do a ileal ureter from the pelvis till the kidney, till the bladder. Instead of, what you can do is you can explant the kidney, implant in the right iliac fossa. If the bladder capacity is good, you can do a Bovary flap to the pelvis, and that is how you can salvage that patient. There are with lot of endourological processes being happening, there could be longer complex strictures where you're not in the position to treat that patient. So to circumvent the loss of the ureteral length, you can explant the kidney and put it into the pelvis, where now the length of the ureter required is very less, and you can obviously use your bladder for it. So bladder, if the kidney is placed in the pelvis, it can very well directly come into the pelvis, so there is no need for ureter in that kidneys. There are suppose it's a solitary kidney and there is a complex tumor, maybe it is sitting into the hilum, it is very large in size and it's a solitary kidney, you want to operate it, then what you can do is you can explant the kidney, put a proper cold perfusion into the kidney, put it in cold ischemia, resect that tumor very well, reconstruct it under loop, take your time, and then you can implant the kidney back into the patient. So these are the certain cases where auto transplant has a role. There is something known as loin pain hematuria syndrome. It is a rare pathology, but what it is severe, unexplained, chronic unilateral or bilateral lumbar pain associated with macroscopic or microscopic hematuria. It was first reported by Little et al. And the surgical indications should include a patient who require high doses of analgesics. So first treatment of choice for this loin pain syndrome is analgesics, but your patient requires high doses of analgesics, then what do? The last resort is auto transplant, and there are studies which have been done, and they have found out that auto transplant, they could salvage the patients out of this. So this is a slide which tells you the indications of kidney auto transplant. So if you, as I said, renal artery pathology, you could have renal artery aneurysm, Takasayo arteritis, FMDs of the arteries, arterial dissection, atherosclerosis, badly atherosclerotic artery, renal vein pathology. Nutcracker is very much common. Renal vein aneurysm is very rare disease. Ureteral pathology, as I said, it is a long ureteral strictures, complex strictures, re-surgeries which have been done on that strictures. There is dense retroperitoneal fibrosis. You can might well remove the kidney and put it in the iliac fossa. There is a tumor involving the ureter. Now ureter, you lost the ureter, what do you do to replace it? So instead of using bowels to reconstruct ureter, it is better you put the kidney into the iliac fossa, and there is no need for bowel handling. There is neoplasm, as I said, it is a centrally located complex tumor, or it is a complex tumor involving a solitary kidney. These are very rare indications where in literature you can find that people have done auto transplant for a very rare indication. Let us just have a glimpse of what are those indication is that kidney transplant was done 21 years ago, and the great saphenous vein was used as an interposition graft, and it had a large aneurysm. So at that time they removed the kidney, did the reconstruction, and again implanted the kidney. Then this is very important, very interesting thing. 2018, so the kidney was explanted and put into recipient. Now the recipient had death because of perioperative heart failure. They again explanted the kidney from the recipient, put it back into the donor. So returned back the kidney to the donor. It has been reported in 2018. Then other cases at aortic aneurysm involving the origin of a renal artery in the functional right solitary kidney. So you have a solitary kidney, there is a big aneurysm sitting just at the ostium. How do you treat it? So you just excise it and do an auto transplant. This is an interesting way to prevent radiation exposure to left kidney, which is shifted away from some disorders was there. They wanted to irradiate that area. The left kidney was coming into the way. They removed it and auto transplanted it. Transplanted renal vein thrombosis after renal transplant, dissectic aneurysm of renal artery, refractory metabolic stone. So these are the various rare indications where auto transplant has been attempted. Now, what are the perioperative assessment that you need to do in auto transplant is that you need to have a thorough imaging assessment, including the CT angio. As you see, the renal artery, vein, ureter, what is the anatomy, single artery, double arteries, there, what is the size, location on the veins, and everything. And additionally, if you are doing for malignant cases, you should have a CT chest, abdomen, pelvis to completely stage that tumor before you go ahead. Now one more important thing is you should have a very well discussion of that case into an MDT, where there is a transplant surgeon, there is a nephrologist. You take an informed decision, because what is important is that after this renal transplant, patient may go into an AKI, have ATN, patient may require temporary dialysis or long term dialysis. So you should have a nephrologist on board, and that is how you should explain the patient. And then preoperative, you should put an HD catheter preoperatively, because the patient may require post transplant auto transplant dialysis. So you should be prepared for it. So this is how it is. You extract the kidney. Now this kidney can be extracted open, lap, or robotically. So these are the various ways you can explant the kidney. Do an bench surgery, whatever the indication is, again reimplant it in either of the iliac fossa where you want it. Suppose the iliac fossas are has some challenges of irradiation, the iliac vessels are not suitable, then in such cases again you remove the kidney and you can put it back to other orthotopic sites. So this is, as I said, that it could be open, lap, robotic in vitro, and robotic in vivo. Now what is the difference between in vitro and in vivo is that you just disconnect the artery and vein, you don't disconnect the ureter. Whatever artery or vein pathology is, you treat it there itself, and again do an anastomosis. There is no need to do an ureteral anastomosis. Okay, so this is robotic in vitro and robotic in vivo. So this is approach based on how do you explant the kidney. So this is various ways they have showed it, and these are some of the studies which shows the feasibility of robotic assisted or kidney auto transplant. And these are the indications for which they have done is either ureteral loss, ureteral strictures, or as I said, there is some loin pain syndrome. You can see some two cases of loin pain syndrome. One is renal artery aneurysm and ureteral strictures. So there are various scenarios, but some studies have a very good number of sample size, which is 32 by Meiji et al. And 29 is Breda et al. So robotic approach is also possible in a auto transplant. Now what are the contraindications of doing an auto transplant? Basically in iliac fossa is if there are severe iliac vascular disease or retroperitoneal fibrosis involving the iliac vessels, and obviously the kidney that you intend to save has a very low GFR, then it is not worth taking all those efforts of doing an auto transplant in that patient. So this concludes auto transplant. Now we'll go to orthotopic kidney transplant. So now the transplant that we generally do is heterotopic kidney transplant, because we explant the kidney and put it into an heterotopic area, which is the iliac fossas, which is not the original location of your kidneys. If you put the kidneys to the original flank position, it is known as orthotopic kidney transplant. Now so orthotopic kidney transplant is a surgery of exclusion. You do it only in the cases where heterotopic kidney transplant is unsuitable. And when are the cases is if there is severe vascular pathology, that is there is severe atherosclerosis of the arteries, there is inferior vein anagesis, so you don't have an iliac veins to implant the vein. In that case, obviously orthotopic is a good choice. Iliac fossas have been, both iliac fossas have been occupied by previous two transplant, then obviously the third kidney I can slightly go up, or you can do an orthotopic kidney transplant. Or suppose you have a condu, and the condu is opening on the right side, and left side is already a transplant done. Now you again have to do a second transplant. In that case, you can obviously go for an orthotopic kidney transplant. See, there's a indications for this. And how do you do it is in donor, it is straightforward. Either you do it open way or the laparoscopic way. So there are two parallel OTs which will happen. Explant of the donor kidney will happen at the same time. Explant of the recipient original native kidney will also happen. Okay, now care has to be taken while removing the kidney is that you dissect the artery, dissect the vein, dissect the ureter, and try to cut the ureter, artery and vein as close to the kidney as much as possible, so that you have a usable length of artery, vein and ureter. While when you put a clamp, you have usable length of artery and vein where you can anastomose your graft artery and your vein. So I will just share a case capsule of one case of orthotopic transplant that we had done. Is was 41-year-old male with hypertension since 6 years, a CKD on maintenance hemodialysis, sister to brother, ABO compatible transplant. It was left kidney to right recipient, right iliac fossa. Uneventful right iliac fossa transplant done in 21. So it's January 21, and there is immediate urine output, and post-op day creatinine is 1.02. Everything is going fine. This is the donor CT of the sister, which is sister to brother. So in Gujarat, you have Uttarayan on 14th of January. So on that day, patient had seizures, hypotension, severe bleeding and pain under surgical site, and we rushed to the OR. And in fact, by that time, the patient was sinking. So CPR was given to the patient but revived, and we immediately opened the patient. There was noticing decreased graft vascularity, perigraph collection. On emergency evacuation, there we evacuated the hematoma, and we found that there is a rent in the external iliac artery quite proximal to the anastomosis. So histopathology of that biopsy of that lesion was taken, or the rent was taken, which was repaired, and it was a necrotizing fungal infection. So this is 14th of January, and again in 15-20 days, in 5th of February, patient presented with severe abdominal pain, swelling in right lower limb, and then again it had bled. Now we knew that this is not going to salvage because of the vascular involvement by the fungus. So this time we did a graft nephrectomy. We excised that part of external iliac artery, and but luckily the post-operative patient did not have any right lower limb peripheral vascular disease. So the limb stayed warm, and there was good movements. So it was second transplant was decided, and this was wife to husband. So this is the angio of the wife to husband. Now we thought of doing orthotopic kidney transplant in this patient, because now the right side you could see. So this is the loss of the artery. So you see, this is the common iliac artery, this is femoral artery, this much length of the artery is not present, but luckily because of collaterals you should, there is a distal devascularization of the limb. That is why limb was not at stake, but we thought that this patient in future may require autofemoral bypass, and that is why we did not want to implant the kidney on the left iliac fossa, and that is why we took a decision of doing it on the left orthotopic location. So what do you know pre-op it is required is, you need to do an angio where you understand how is your renal artery. So this is the renal artery, it is good sized. This is the renal vein. You see the renal vein is quite good. This is recipient's angiography being done. Now you see this is the left ureter. You can also do an RGP because they are no excreting kidneys. So you should need to know the anatomy of artery, vein and ureter before you go for an orthotopic kidney transplant. So as I said, in view of left to right iliofemoral bypass, we did a left orthotopic kidney transplant in this patient. And as you see, we followed all the steps. We did an anastomosis. So this is how it was done to show to it. So we explanted the original kidney. We did an end-to-end spatulated anastomosis of donor artery with the recipient native renal artery. Again a donor renal vein with the recipient renal vein. This was end-to-end anastomosis, and then we put a DJ stent, which is normal length DJ stent, which is 6 by 26. and then again we did a spatulated end-to-end anastomosis of the ureter. And finally this was the picture it looked. The other thing that we did is, so we intentionally kept a pad of fat at the upper pole of the kidney, and we did a nephropexy with a psoas muscle which was present over there, so it does not there is no ptosis of the kidney. If you can see, this is the post-operative x-ray of this patient, where you can see a normal looking digestant. So transplant digestant would start somewhere from here, but since this is orthotopic kidney transplant, you can very well see the kidney is placed in the left flank, and that is how this is we could salvage that patient by doing a left orthotopic kidney transplant. This is the transplant kidney in the left renal fossa with very good vascularity, and the post-operative course was uneventful. We thought that we would require the DJ for a long time. That is why we had kept a percuflex digestant, but we removed that to a month. And nadir creatinine was 1.1, and the latest creatinine, as you can see in July 2025, it is 1.28. Almost 4 years have been gone. And as you can see, this is the largest series of orthotopic robotic kidney transplant by Breda et al, and this is from the EAU robotic kidney transplant working group. And they did 16 cases, and there was conversion only 2 cases. Conversion to open case only in 2 cases, but the outcome was also good. So this just shows the feasibility of doing orthotopic kidney transplant robotically. This is again a meta-analysis which shows that it can be very well done, but this is the complications that they had. So vascular complication was 19, and urinary complication was 52. But if you see, the overall survival 88 to 95, and the graft survival was 83 to 90. So anywhere from 80 to 90 was the graft survival. So to conclude, kidney auto transplant is very good option for in vitro management of complex vascular, ureteral, and tumor management. Orthotopic kidney transplant is a good alternative option when orthotopic kidney transplant cannot be performed due to severely affected iliac vessels, previous transplant, or urinary conduits. It has a good graft and patient survival outcomes and should be a part of our armamentarium whenever we need it. So this should be always at the back of the mind when we are evaluating some complex recipient. Yes, we can do orthotopic kidney transplant. That is the moral of the story. Thank you.